Hello everyone, welcome back to another day of our free NCLEX review course. For those who just joined us, we are inviting you to enroll in our comprehensive NCLEX review course at stancoast.com. And we are on day 37 of the 90 days free review classes for the NCLEX. Now, we are really encouraging you to enroll as we do have a lot of wealth of resources. About 3,000 NCLEX style questions with 10 hours of animated videos for your studies. And we really want to make sure that you are confident before you take the examination. Now, kindly visit our website at www.stancoastnclexcoaching.com. And you can also check the description box below. And also make sure that you post your questions, your feedbacks regarding our lectures, and we'll be happy to help you out. Now, today we'll be talking about the different problems in the heart rhythm. So focusing on the different dysrhythmias and also the nursing management, and we'll also tackle the different NCLEX questions related to those. Now, this is going to be a little bit kind of condensed with the 12-lead EKG, the basics of interpreting the EKG, but our focus today will be more of the nursing management. Now, as we know that electrocardiography really is going to involve the use of a machine. We call that as the electrocardiogram in order to record the heart's electrical activity. This is going to be connected to the patient's chest through the wires or the leads, and this will be placed on their chest and also to the limbs. Now, it is very important for you to be familiarized that with patients that may have problems in their heart rhythm, they probably would need to have continuous cardiac monitoring. That would probably require the patients to stay near the monitoring system. It could be a tally box, and this going to be monitored by the telemetry technician or the nurse themselves in order to check for any of these abnormal rhythms that may come in and out while the patient is in the hospital, right? And also, for those clients that are undergoing continuous ECG, they should be monitored and they should be informed that this machine or the continuous ECG monitoring will not detect symptoms such as shortness of breath or chest pain or anything that could be associated with acute coronary syndrome. And so they should be educated that they should report any worsening symptoms, okay? Let's say chest pains or lightheadedness. So make sure that they know about these things. Now, we get a review on the different indications about the use of the continuous cardiac monitoring. And for those who just came into the classroom, welcome, Jacqueline. All right. One of the indications here would be the sinus brady or tachycardia. We have the AV blocks, and there's a lot of varieties, first, second, type 1, type 2 AV blocks. We also have the third degree. Atrial fibrillation is very common, and probably this will come up more in the exam. There's also ventricular asystole or premature ventricular contractions, or the PACs. SVT could be the ventricular tachycardia, ventricular fibrillation. So these are things that you might often see in the clinical setting or also in the exam. Okay, so just get ready with what may come out in the examination. But again, our focus here will be to refamiliarize the different nursing actions and also to be familiarized with the kind of pharmacological treatment that will be given to this patient. All right. Now, hello. Welcome for those who just came into the classroom. All right, let's move on to refamiliarizing the different important aspects when you are looking into the EKG. All right. And so when we are going to be tasked to review or assess the waves, of course, we're going to need to know first the different sizes or the significance of these boxes, right? And so we have here our PQRST waves, and of course our boxes right here. The small box basically is going to be equivalent to a 0.04 second. Okay, please don't forget that. And a bigger box or large square, which is basically this one. Let me try my pen and see if I could do it better. So that is equivalent to about 0.2 second, or it contains those small 5 boxes, right? And for a big, large boxes, so that could mean that it could have a duration about 1 second. All right, so don't forget those. Very important duration for a small box, a bigger box, and 5 large squares. All right, now let's take a look into the P wave. Let me erase this first. The P wave basically is going to have a duration of 0.6 to about 0.111 second, but you don't really have to memorize this section about the P wave itself. What we'll know more is about the PR interval. And so just noting about the P wave, this is a wave that actually represents the contraction of the atria. Okay, let's simplify this. Atrial contraction. So you see here in the section. Now it will actually tell you that this is the time that the upper chambers of the heart, the atria, the right and the left, are starting to contract. So that's the start of the ECG. Now, when we are going to look into the PR interval, basically this is this section right here, wherein it will represent the time for the electrical impulses to travel from the atria through the AV node into the ventricles. Okay, so here we have our PR interval. Again, it represents for the electrical impulses by the time when they're traveling from the atria to the AV node. Okay, PR interval. And here we really need to know about the duration. This is very important. The duration is 0.12 to 0.20 seconds. Okay, or it's equivalent to about 120 to 200 milliseconds if you prefer it that way. And you'll see the next waveform here. We have the QRS complex, of course, this one right here. And the QRS complex has that duration about 0.6, okay, or 0.06 rather, QRS complex. It has a duration of 0.06 to 0.10 second. It's much more, it's narrower compared to the PR interval. So take a look into that duration right here. It's shorter. It's only 0.06 to 0.10. Now, what does the QRS complex signify? Well, the QRS complex will tell you that here the ventricles are now contracting, okay? Depolarization of the ventricles, contraction of ventricles. All right, so just simplify that. It is the time when the ventricles are contracted. They're now starting to pump the blood out from the lower chambers. Okay, now let's also talk about the ST segment, which is this section right here. The ST segment has that duration of about 0.08. 0.08 to about 0.12 seconds. And this is going to represent that the ventricle is now starting to relax, repolarization. Again, the ST segment has that duration of about 0.08 to 0.12 seconds. And this signifies that the ventricles are now starting to relax, the repolarization phase. Now, talking about the next wave right here, which is the T wave. This is going to represent the ventricular repolarization. All right. So just want to make sure, guys, that you understand the ST segment is the time wherein the ventricles are now starting to relax, early ventricular repolarization. However, our T wave basically represents the ventricular repolarization or relaxation. Okay, so again, to recap, I want you to recall the normal duration for the PR interval, the QRS complex, and the ST segment. So these are the key values that you need to recall in order for you to identify if there's any widening or narrowing of the complexes, and also if there's some what do you call this, widening, or the PR interval is much more prolonged. Okay, so if there's going to be issue with the PR interval, it's probably going to be much more prolonged, then probably the patient will have some AV block or atrioventricular block. Now let's talk about the analysis of the EKG, and we're going to use the 6-second rule, which is going to be applicable only if the patient has a regular heart rhythm. So what is this 6-second rule? Well, this is very straightforward. This is the method that we can use when we have that 6-second interval on the EKG paper. And so you will see that there's about 30 large squares in that 6-second strip. Okay, so let's take a look. There's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So this would really be required for you to do that 6-second reading of that regular rhythm in an EKG. All right. So what are we going to do here? We are going to count the number of RR intervals. So these are, this is the time between the successive R peaks, which are these right here. Okay. And take note that we have 30 squares, all right, in a 6-second strip. So what we're going to do here is we're going to have to multiply the number of the R peaks by 10. Okay, so the number of R peaks, we're going to multiply it by 10, and that would be the heart rate per minute. Okay, so how many R's do we have here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So quite in the borderline, right? So possibly any more of that can lead to sinus tachycardia. So we are about like 100 beats per minute, right? Is that correct? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it is very important, guys, that when you are using this type of technique, again, this is only applicable when the patient has regular rhythm. When you're looking into a 6-second strip, and check first about the regularity of the QRSs or the peaks, the Rs, the P waves. Take a look on those first. Okay, so make sure that do not neglect those waves, the intervals, the segments, the complexes. Another is that you're going to have to look for the P waves as well before the QRSs, right? So make sure that you're going to have to identify those first. In a normal sinus rhythm, take a look into the P waves. Again, they signify the atrial contraction, right? While the QRS complex indicate the ventricular contraction. So this is just very basic, guys. Now, about the T wave, don't forget about that. The T waves are those waves that will represent the ventricular relaxation. The ventricles are now repolarizing before the heart will start pumping again in the next cardiac cycle. Now, another thing that we need to review is that the segments like the ST segment or the intervals such as the PR or the QT intervals, we really need to keep an eye on those. So for example, the PR interval will measure the time when the impulses are being transmitted from the AV node, from the SA to the AV node, right? Or this will determine the travel time for the impulse from the atria to the ventricles. Now, here we also need to recall, guys, that what else? We have the QT. I think we got that one already. The PR interval. I talked about the QRS. Now we're going to have to go into the next section here. We're going to identify now the abnormal heart rhythm. So starting with the sinus bradycardia. You'll see here that the intervals, the spacing between the QRSs, they're quite widened. I mean, it's kind of spread out looking. And so this is a 6-second strip, right? Got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 3, and 4, and 5, and 6, 7, 8, 9, 30. 30 large boxes. And take a look into the R waves. It looks regular, right? When you're going to look into a sinus bradycardia rhythm, it will look regular. Of course, it still has the QRS, it will have the P wave, it will have the T waves. Now, look at that. That's about 1, 2, 3, 4, 5. And you're going to multiply it by 10. That's only about 50 beats per minute. Okay? And so when we're going to consider reading a sinus bradycardia, always think that it will be less than or slower than 60 beats per minute, right? Less than 60 BPM. Now, when you are looking into this patient, probably they're complaining that they are probably lightheaded for some, and some of these patients probably are asymptomatic, and some will be symptomatic. And so if they're going to be symptomatic, let's say they are lightheaded, maybe they're getting nauseous, or probably they feel like they're about to fall, then we're going to need to address the underlying cause. Maybe the patient has a problem with the thyroid gland. It could be caused by hypothyroidism. Or maybe the patient has been taking a beta blocker and it's really slowing their heart this time. Maybe it's no longer applicable. It's no longer appropriate for this patient to be taking a bigger dose of the beta blocker. And so this is something that we need to assess, guys, when they will end up with bradycardia, or maybe they are taking digoxin for their heart failure, and it's now causing their heart rate to go down. Now, when we are going to have a patient with a symptomatic type of sinus bradycardia, maybe in the low 20s, 30s, that's really low, guys. And so you got to be ready. Make sure that you're assessing the patient. You have to have that visual of your patient, not just looking into the monitor. Make sure that you are talking to them. Hey, are you doing okay? How do you feel right now? Do you feel anything? Are you lightheaded? Do you feel nauseous? Do you feel like your surrounding is kind of spinning around you? And so make sure that you do collect, you have to collect these observations in order that we can correlate this with the EKG rhythm. And if they will become symptomatic, let's say if their blood pressure will go down or their cardiac output will go down, Yeah, that's going to be significant, right? It can compromise the blood supply to the major organs as well. And so we are going to report this to the medical provider once they are symptomatic. All right. Now, possibly the patient with a significant bradycardia, they might need more monitoring. They will. Ongoing cardiac monitoring. We're going to have to do much more of vital signs frequently. We'll have to check for their adequate perfusion. Okay. So again, our nursing responsibilities, we'll have to check signs and symptoms. We're going to have to check your vital signs, and then also to check for adequate perfusion. As we know that when there is low heart rate, it can impair the heart function, right? The heart will no longer be able to produce that adequate amount of cardiac output to supply the body organs. So make sure that we are checking that one. Adequate tissue perfusion. Now, moving into the next, before we go to do that. Now, if we identified maybe the patient has been taking the beta blocker, maybe recently they just started taking the beta blocker. So you're going to have to notify the doctor that, hey, our patient just started taking the metoprolol a few days ago, and now the heart rate seems to be dipping into the 30s, especially early in the morning. Or they just started taking the digoxin a few hours ago or days ago. So these are things that need to be reported to the physician. Maybe an adjustment of the digoxin dose or the beta blocker will be required this time. Or to address the hypothyroidism of our patient. Maybe they're going to need some synthroid or that synthetic form of thyroid medication. Now let's move forward with the next arrhythmia, which is the sinus tachycardia. So this is going to be that rate that exceeds 100 beats per minute. So the P waves, QRS, R waves, T waves are all there. Okay, it's just that the rhythm is a lot faster. It exceeds 100 beats per minute. And what we can do here is to identify what really is causing the rapid heart rate. Is it caused by the stress? Or is it caused by fever with an increasing metabolic rate? Or is it caused by the caffeine intake? So these are the things that we need to figure out why the patient is developing the sinus tachycardia. Stress, fever, caffeine, or maybe they are probably taking some methamphetamines, right? Stimulants. And this is very common, especially in the acute care setting. Now, probably the patient will end up with some kind of like chest discomfort when their heart rate goes above sustained in the 120s, 130s, 140s. When their heart is going to be in a lot of stress, the myocardium is working too hard, they're going to end up with that chest pain at some point, which will lead into probably ischemia, or it could be the infarction if it's not addressed. Now, expect here, guys, that when we are looking into a patient with a sinus tachycardia, expect that we're going to probably be medicating this patient with a beta blocker, okay, metoprolol. This will slow down the heart rate, of course. Or we are going to administer calcium channel blocker. Calcium channel blocker. CCBs that we mentioned yesterday. Calcium channel blockers. And again, our aim here is to slow down the heart rate, or slow the heart rate. We don't want our patient to have a prolonged tachycardia, because eventually it will get tired, it will get exhausted, and it will have a problem with ischemia on its own. Now, what we need to do here is to make sure we are identifying the cause. And if we had identified that, then we're going to treat the cause. Is it the stress? Is it the fever? Is it the caffeine? So we want to make sure that the patient is educated about those possible causes and advise them to stay away from those. Okay, now let's move on to the next problem here. We're going to talk about the heart block, starting with the first degree AV block. So the problem here is the patient has now a prolongation in their PR interval. Okay, so what's going on? There is now a prolongation in the PR interval. So if the patient has a prolonged interval, let's say 0.21 to 0.24, this is considered as a slight block. Okay. Now, if the patient's PR interval will be prolonged, let's say 0.25 to 0.29, and this is already considered as a moderate block. And we're still talking about the first degree heart block, guys. Now, if the patient's PR interval is much more prolonged, let's say greater than 0.30 second, then that is already considered a severe heart block. Now, the problem itself, it is something that can occur even in a healthy individual. Maybe the patient has been taking some kind of an antiarrhythmic medication, or maybe they have been probably had a rheumatic fever, or maybe they have some electrolyte disturbances. Okay, so let's talk about the causes here in first degree heart block. Again, one of those is possibly with the use of antiarrhythmic medication. It could be with digoxin, or it could be the beta blocker, or let's say the patient may have electrolyte disturbances. And what are those disturbances that may affect this patient? Well, it could be low magnesium, or maybe the person has a low potassium level. Okay, low potassium, low magnesium, or they might have hypothyroidism. And this is something that can also occur in those people that may have the inferior wall MI and also myocarditis. So these are the possible causes of the first degree heart block. Now, when you're looking into the strip, the atrial and the ventricular rhythm are actually looking regular. Okay, we're looking regular. The rates are probably usually 60 to 100 beats per minute. The P waves will appear normal. They will appear normal. It's there. But the PR interval is already prolonged and it's becoming more constant. As I have said earlier, there are certain levels of the first degree heart block. There's that mild, there's that moderate, and there's that severe. So please take note about the increments in the widening, or the prolongation rather, of the PR interval. Now, in a patient with a first degree heart block, sometimes they are asymptomatic, and sometimes they might have some slowness in their pulse rate, or it could be normal. And what we can do here, guys, since the patient may be having some electrolyte imbalances, then we're going to have to treat those imbalances. So if there is hypokalemia, then we're going to have to replace that. Or if there is hypomagnesemia, then we're going to have to replace the lost electrolyte. And Another thing is possibly we're going to administer atropine sulfate, okay, if the patient becomes symptomatic. Atropine sulfate if they become asymptomatic, rather symptomatic, not asymptomatic, and this is going to be given IV. All right. Again, the atropine sulfate will be given to a symptomatic patient and when they have that bradycardia. Another thing that we can do for this patient is to correct the electrolyte imbalances, replace potassium, replace the magnesium. If they have hypothyroidism, we'll take a look. Have they taken their daily dose of the synthroid or levothyroxine? Okay. Now, in this patient that may have a new diagnosis of first-degree heart block, what we need to do is to carefully monitor their heart rhythm. This is very important if this is a new diagnosis. And again, with the appearance of much more prolongation of the PR interval, this is something that we need to capture right away, okay? And if the patient becomes more symptomatic. Now, let's talk about the second-degree heart block, Mobitz type 1, okay? This is our second-degree AV block, Mobitz type 1, or this is what we call as the Quebec type. Quebec type of heart block. So what is this second-degree AV block type 1? Well, again, this is resulting from a diseased AV node tissue, okay? So the cause here, diseased AV node. And here, the AV node is conducting the impulses increasingly earlier in the relaxation period, okay? And an impulse will arrive during the absolute refractory period, so it will not be conducted properly. Now here, in the second-degree heart block type 1, this is going to occur especially for those patients that may have the inferior wall MI. Inferior wall MI, or it could be caused by acute rheumatic fever, or maybe vagal stimulation, bearing down, pooping on hard stools. This can result to that as well. Vagal stimulation when the patient is holding their breath, or it could be caused by digitalis toxicity. Okay, so that's another one. Patient will go into a type 1 second-degree heart block. Or maybe they are taking the propranolol as well, the beta blocker. And probably procainamide, quinidine, those anti-arrhythmic medications. So let me just write here, quinidine or procainamide. So these are known medications that will slow down the heart rate of the patient. So again, we got digitalis toxicity, propranolol, quinidine, procainamide. These are the common causes of the second-degree heart block type 1. So when you're looking into the P waves or the PP interval, let's take a look. P. So we're still seeing those. Well, you will see that a portion of the strip will have some kind of a regularity, right? There is some uniformity of the P waves. However, it will become progressive. There is going to be a progressively shorter R and R interval. So after several cycles here, there's going to be a missing QRX complex. So take a look into this. There's a missing QRS complex. Yeah, I know. We're going to talk about those AFib and bradycardia. missing QRS. All right, so this is our Mobitz type 1 second degree heart block. So again, with the progressively longer PR interval, there's going to occur that RR interval will become shorter as well. And then after several cycles, we will be noting a missing QRS complex. Then the patient will probably more symptomatic this time, okay? They probably would feel that already, as we know that there is a ventricular irregularity. There is shortening of the RR interval, and the P wave appears probably without a QRS complex. So this is going to really cause issue into our patient. Now, our patient would be probably complaining something, lightheadedness. They probably would get nauseous, and some probably would not complain anything because they still have that regularity, but a little bit of occasional irregularity. So you really need to pay attention into their manifestations. So what are we going to do here for this patient with the type 1 second degree heart block? We're going to treat the underlying cause. So if the cause was digitalis toxicity, then we're going to have to treat that. Remember about the digibind, which is the antidote for the digitalis toxicity. If the medication that's causing the type 1 second degree heart block are the following: propranolol, quinidine, procainamide, then we need to report this to the medical provider. Hey doctor, our patient who's just been started on these medications is now developing the type 1 second degree heart block. So possibly these medications will be held or would be withheld for the meantime. And we're going to have to investigate further what really is causing this. Or maybe is it the inferior wall MI, or maybe the vagal stimulation. So we really need to investigate and identify what is really causing this manifestation. Now, our care for this patient is to continuously monitor our patient in the acute care setting. Make sure you do your periodic checking, vital signs checking. You have to really check with the technician. Hey, is something coming up with my patient? Are there any more ectopic, or are there any more abnormal waves going on with my patient? Or is there any worsening of the heart block? And so if in case that we have identified this, and if the patient is symptomatic, then we are going to prepare to administer atropine sulfate. So again, we are going to prepare to administer atropine sulfate if the patient becomes bradycardic and if they are symptomatic. Again, we are going to be ready in administering the atropine only when the patient is bradycardic and when they are symptomatic. The same thing with the first degree heart block. Now, moving forward with the next one, we're going to talk about the second degree heart block type 2. So what is this? This is what we refer to as the classic second degree heart block. Classic second degree heart block. And this is a result when a conduction disturbance in the His-Purkinje system causes this intermittent blockage of the electrical impulses. Now, some of the causes for this type 2 heart block, we're still talking about the second degree here. It could be caused by organic heart disease or maybe acute anterior wall MI. Acute anterior wall MI. Or it could be a severe coronary artery disease, severe CAD, or it could be acute myocarditis. So guys, with this type of heart block, there is usually no warning on the EKG before the heartbeat is being blocked And there can be any number of drop beats before a beat is conducted. So take a look right here in these sections where the Mobitz type 2 are located. Okay, so take a look into those areas. There's going to be what we call as drop beats. Okay, so there's no warning when it can actually happen. And also the patient will have that characteristic regular atrial rhythm. They still have that kind. Their ventricular rhythm, the QRS complexes, will still look okay. But again, they will have that occasional drop beats. Now, when we are looking into the PR interval of this Mobitz type 2, the PR interval will look like they are within the normal limits. They will appear constant, then they're going to be followed by the QRS complex. However, there will be that occasional appearance of those dropped beats. Now, what would be the manifestations here in our patient with the type 2 Mobitz? Well, this time they might manifest some bradycardia, or they might have still that normal heart rate. So it can vary. Bradycardia rather to normal heart rate. Maybe their heart rhythm would be regular, and sometimes they will become irregular. Regular or irregular. And now we're going to have to look for those signs and symptoms of decreasing cardiac output as well. Decreased cardiac output. Now, what are those signs again? Maybe they're still complaining about the lightheadedness. Probably they're feeling nauseous. They just feel like they're about to fall. They are kind of like unstable. Their gait is, hey, just feel like I'm kind of like spinning already. And so investigate or talk to the patient about these manifestations. Make sure that you are obtaining these kinds of information, because some of these patients really would not report anything. Now, what we're going to do here, we will continue monitoring the patient's cardiac rhythm. We'll have to monitor if the AV block will worsen. And guys, what we will do here is to prepare for the placement of a temporary pacemaker. Prepare for temporary pacemaker. So this is what we call as a transcutaneous pacemaker. And this is something that we should be ready when the patient is becoming bradycardic and they are symptomatic, because the cardiac output now is affected. Okay, so again, we are going to prepare ourselves for the placement of a temporary pacemaker, or this is what we call as the transcutaneous or external pacemaker. Transcutaneous. This is external pacer. And this is going to be used in an emergency, okay? So the nurse should be prepared when this second or type 2 Mobitz type occur to this patient. Now, we're going to have to monitor the patient's level of consciousness when this occurs, guys, because again, the cardiac output is affected. So another nursing care here is to monitor LOC. Also the vital signs, we need to do that. And make sure that we are monitoring for any other signs of decreased cardiac output. Nail beds, urinary output, okay? Their saturation. So these are things that we need to keep an eye on, okay? Now we're going to talk about the next heart block here, which is the third-degree heart block. So what is this third-degree AV block? So basically the patient now has a complete heart block, and this is going to be the result of no impulse being conducted from the atria to the ventricles. So again, there is no more impulse being conducted. No impulse conduction from the atria to the ventricles. Take a look at that one. That's 30-degree heart block. So here you will see that there is that what we call as the ventricular rhythm, or the junctional escape, or the ventricular escape. And so with this kind of rhythm, the ventricular escape rhythms are becoming slower, less stable, and our patient here is at a higher risk to developing what we call as a ventricular standstill, and also a decreasing cardiac output. Ventricular standstill. Their cardiac output rather is severely affected. Decreased CO. Now, what could possibly cause the 30-degree heart block? There's many. Okay, one of those is digitalis toxicity. So if there was no proper monitoring of the cardiac glycoside digitalis for this patient with a congestive heart failure, they're gonna possibly have this 30-degree heart block, or maybe this is going to be caused by the inferior MI, inferior wall MI. And sometimes when there is an irritation into that tissue in the heart during a cardiac catheterization, it can also occur. Cardiac catheterization. Okay, so that's it. 30-degree heart block. Now, what are we going to do here to treat this patient? We're going to have to monitor our patient's heart rhythm continuously. We're going to have to check for any worsening, and we are going to administer the, where's my pen? Treatment. We're going to have to administer atropine sulfate, IV. And if they become symptomatic, or if their heart rate drops below 60, or let's say 40s, 30s, then definitely we need to administer the atropine sulfate. Now, another nursing preparation here is to prepare the patient for the placement of a temporary pacemaker, the transcutaneous pacemaker, temporary pacer, or what we call as the transcutaneous pacemaker. So our goal here is to make sure that we are capturing any more, or we're not wanting to cause worsening of the heart block. So make sure that we are looking into the heart rhythm continuously and treating that with the atropine sulfate to prevent more complications. So again, your patient's level of consciousness will be assessed here. This is very important, as we know that if there is decreased cardiac output, it can alter the patient's level of consciousness. It can also decrease the blood pressure. So we're going to make sure we are monitoring the patient every now and then. Now let's talk about the next dysrhythmia, which is the A flutter. So what is the atrial flutter? This is a problem in the atria wherein the heart rhythm will have that kind of regular, but it is going to be rapid atrial rhythm. Regular, but rapid atrial rhythm. And as you notice in the picture, you see that typical sawtooth appearance. And that is caused by, this is the P wave appearing, okay? So those are what we call as the sawtooth appearance in this patient with a flutter or atrial flutter. Now, what you're seeing is actually that the atria are contracting regularly. On here, what you're seeing is that the rate here will probably be about 250 to 350 per minute. So the flutter waves has a rate of about 250 to 350 beats, or yes, beats per minute. So that's what we call as flutter waves. Okay. Now, when the patient has the A flutter or atrial flutter, what do you think can happen to them? They're going to end up with some palpitations, bounding chest. They're going to have that. They're going to end up with a shortness of breath, the difficulty of breathing. There's also dizziness because of the compromise in the cardiac output. And the symptoms will be quite similar with the atrial fibrillation. Okay, so with atrial flutter, the clinical presentation may vary depending on the ventricular rate. Okay, so you got to keep an eye on that one. And in order to manage this patient, what we're going to need to do here is to control the heart rate. So nursing care is to control heart rate, control HR, or probably would need some cardioversion. So we're going to prepare the patient for cardioversion. And in some cases, the patient will probably need to have catheter ablation as well in order to eliminate the abnormal electrical pathways causing the atrial flutter. Again, our patient's rate will be so rapid, they're going to end up with the bounding chest pulse, palpitation, shortness of breath, dizziness, and we want to control that rapid heart rhythm. We probably would prepare them to have a cardioversion or ablation. Now, moving forward to the next problem here is the atrial fibrillation, very common type of arrhythmia that is characterized by irregular electrical activity in the atria, which are the upper chambers of the heart. And so when you are seeing this in a patient, AFib, the electrical impulses in the upper chambers are so disorganized. Atria impulses are disorganized. So let's just talk about quivering, okay? Chaotic type of impulses originating from the atria. So instead of the normal coordinated contraction of the atria, it will now generate rapid, very irregular electrical signals that could come from the multiple locations from the atria. So it will be everywhere in the atria. It will originate just anywhere in the atrial chambers. Now, when we are talking about the atrial heart rate, this is going to be irregular, and it can range from heart rate is irregular, and the range will be somewhere between 100 to 180 BPM, okay, or greater than that. Okay, it depends on the heart condition of the patient, but again, this is going to be the range, about 100 to 180 beats per minute, irregular rhythm. Again, the reason for this AFib, it is because of the irregular firing of electrical signals coming from the atria. So it's like having a party inside the atria. There's just way too many people producing the electrical impulses. So it will cause that disorganization, chaotic sending of the impulses. And it will not be able to cause proper emptying of the blood from the atria into the ventricle, because it's just too excited but not effectively pumping the blood from the upper chambers to the lower chambers of the heart. Now, when you are seeing a patient's EKG with AFib, please take note, guys, that there will be absence of P waves. Absence of P waves. All right. So you will not be able to see that one. Okay. Now the R intervals will become irregular. Okay. Irregular R to R intervals. Okay. So don't forget about the absence of the P waves, and the intervals between the R's are becoming irregular. So take a look into the distance from this one to the next. So this one is a little bit wider, and then back to the usual one, and then it kind of looks a little bit narrower. So it's quite irregular, guys. Now, for the patient having the atrial fibrillation, what do you think would be the manifestations in this patient? Well, of course, they will complain that there is palpitations, right? They will sense that there is some kind of like fluttering or pounding heartbeats. Let me write that down. Manifestation. Whoops. Sensation of fluttering heartbeats or pounding heartbeats. Fluttering. How did I do that? Fluttering heartbeats. Pounding heartbeats. Fluttering heartbeats. There also probably going to be a shortness of breathing. SOB. Shortness of breath. They probably would end up with chest discomfort. And maybe they will become fatigued because they're not getting enough oxygenation, because the atria are just way too busy but ineffective in pumping the blood coming from the atria to the ventricles. So again, they will become short of breath. They probably would end up with chest discomfort because the heart itself is not getting enough blood supply or oxygen. They will feel that sensation that their chest is pounding. They probably would start to get confused, disoriented, or they may feel some lightheadedness as well. So our problem here, guys, is cardiac output decrease. So perfusion is a huge issue in a patient with atrial fibrillation. Blood supply to the brain, blood supply to the major organs. So take note about the manifestation. You correlate this with the rhythm. Now, what would be the possible complications when the patient has the AFib? What do you think? What do you think are the complications? Whoops, not wanting to go there yet. Let me erase. What are the complications? Remember about what I said in the previous topic the other day on the atrial fibrillation. It can cause pooling of the blood or stasis of blood in the upper chambers of the heart. Okay. So there will be pooling of blood in the upper chambers. So there will be stasis. Yeah. When this happens, when the blood stay a little bit longer in the upper chambers of the heart, this can lead to the formation of the blood clots. Okay. So this is something that you need to anticipate. Hey, our patient has a new diagnosis of AFib. And you really going to be proactive here, because our patient will possibly going to throw a clot. They're going to end up with a stroke. And this is a common complication, guys. Okay. Now, what are we going to do here? Again, we're going to have to manage the irregular rhythm. What we're going to do, we're going to have to include the administration of anti-arrhythmic drugs. Okay, let me erase this section over here at the bottom. Since there is stasis of blood in the upper chambers, then what do you think would be appropriate for this patient? Well, we're going to need some form of anticoagulation. PO, oral anticoagulation to prevent the formation of the blood clots. Could be warfarin, Coumadin, or it could be any of the oral blood thinners. And we're also going to have to treat this patient with antiarrhythmic medications. Could be the cardizem, okay, to slow down the rate, or it could be the beta blocker as well. Beta blocker, or it could be a calcium channel blocker to slow down the atrial rate. And in some cases, we're going to need to prepare the patient for cardioversion as well. That's important. To restart the patient's heart. Okay, that's one thing. And also part of the care here, if they are known to be an alcoholic drinker, we're going to have to educate them to diminish their intake of alcohol. All right. So don't forget about AFib. There is irregularity in the firing of the impulses coming from the atria. It's so busy in the upper chambers. The patient will end up with SOB, shortness of breathing, fluttering sensation in their chest. There's also going to be some decreased cardiac output because of the ineffective pumping of the blood to the circulation. And also with the risk that they're going to develop the clots, we're going to have to treat this patient with anticoagulation. We're going to have to treat them with antiarrhythmic meds, such as the beta blocker, or it could be the calcium channel blocker. Or we're going to have to restart the patient's heart with the cardioversion. Okay. Now we're going to move on to the next item here. We're going to talk about the ventricular tachycardia. So what is this? This is a rapid heart rate that is originating from the ventricles of the heart. Rapid heart rate originating from the ventricles. Now, we are going to note here, guys, that the heart rate will be exceeding 100 BPM. It exceeds that. And the rate could possibly go as high as into 200s. That's crazy, right? I've had a patient that I had taken care of. He was a post-op. Just a brand new right below knee amputation. And then one morning around 4 a.m. while I was assessing this patient, because he was just like a fresh post-op, right? Like about 12 hours before my shift. And so when I did my morning assessment, he was saying that he's having some pain into the surgical site. And yeah, I said, yeah, let me check your vital signs first, and I will have to get your pain medication right after. And so when I took the patient's pulse oximeter reading, immediately it went up into like, yeah, it was like in the 200s, like, that's kind of weird. And so I continued checking the blood pressure and everything, the pulse rate. I did apical pulse, and that was rapid. I could not even count. And so immediately I was like, hey, maybe this is about the pain that he was like denying previously, because he did not really want to take any pain medication. And so, yeah, I pretty much understood that this is probably caused by the pain as well. But aside from giving the pain medication right after that happened, I called the rapid response team. Just want to make sure everything is okay, because this was out of nowhere. It just happened, right? And so we ended up giving the medication to the patient. We gave him the cardizem, and eventually heart rate slowed down. So things like that would really excite you guys, especially like when you are not prepared. And so with the ventricular tachycardia, guys, this is going to occur especially when there is disruption in the heart's electrical system. Maybe it's caused by a scar tissue from the previous heart attack, or maybe the ventricular tachycardia is caused by a structural heart disease, or it could be caused by an electrolyte imbalance. All right, so you gotta have to investigate what could possibly cause the VT of this patient. Now, when you are looking into the patient's EKG, as right now, you're going to see that there is abnormal, or there are abnormal QRS complexes. The QRS are, the complexes are actually greater than 0.12. Okay, so this is our criterion in looking up the ventricular tachycardia. There are abnormal QRS complexes greater than 0.12 seconds, and they're going to occur in rapid succession. Okay, and when you're seeing this, it looks quite uniform, right? So this is what we call as monomorphic type of ventricular tachycardia. So they're looking at the waves are looking pretty much the same. So this is what we call as monomorphic. Monomorphic. But there's also that variety we call as polymorphic, wherein there's different waves of the QRS complex, aberrant QRS complex. Now, when you are going to ask this patient, hey, how are you feeling right now? Well, the patient will complain of the palpitations. They will feel like they're having some dizziness. Okay, so those are the manifestations. Let me just write. The manifestations are the following. They're going to have palpitations. There's also lightheadedness. And probably some chest pain. Let me just put there as CP or syncopal episode, or syncope. Near fainting. So this is really signifying that the patient now has a reduced cardiac output. So the body is no longer able to receive that adequate amount of blood coming from the heart because of that rapid heart rate. Okay. Now, when in severe cases, the ventricular tachycardia can also lead to a much more life-threatening problem we call as ventricular fibrillation. So it's very important, guys, that we're going to address this right away. Now, what are we going to do to help this patient with the VTAC? We're going to have to treat the underlying cause. We're going to have to administer the patient amiodarone. Okay, we're going to have to give them amiodarone treatment. So our treatment here is amiodarone and or lidocaine IV. Okay, the patient will also probably receive a synchronized cardioversion. Okay, so this is another treatment for this patient. When the patient becomes unstable or they will become symptomatic, let's say their heart or the cardiac output is already compromised. Now, for this patient that has the ventricular tachycardia, we're going to have to manage this in the long term. We're going to have to identify, we're going to have to treat the underlying causes, and possibly the medical provider or the cardiologist will recommend the placement of the implantable cardioverter or defibrillator. So that's another one. Okay, let me write that down. Long-term care for a patient with this kind of arrhythmia will be the placement of the automatic implantable cardioverter defibrillator. So this is the automatic implantable cardioverter defibrillator. So this will be placed surgically, just similar to placing a pacemaker under the skin of the patient. And the reason that the AICD is going to help the patient is that it will terminate the life-threatening arrhythmias. Yeah, it will do that. It will terminate the life-threatening arrhythmias, I should say. Okay, moving on to the next one. We have the premature ventricular contractions, and these are very common, guys. You probably encounter this more than the others when you're going to be working in the med-surg setting. So what are these premature ventricular contractions? They are that irritable ventricles. They are firing way too much electricity, okay? So here, you're going to see different variations of the PVCs. So this is what we call as the bigemini. So it simply means that the premature ventricular contraction is occurring every other beat. So here's one, and then the patient goes into a normal cycle, and then here's another one, and then the patient goes back into a normal cycle, and then another PVC will occur. So this is what we call as bigemini. The premature ventricular contractions will happen every other normal beat. Now there's also what we call as trigemini, which is a premature ventricular contraction that can occur every third beat. So there's that. Normal, normal, and then a PVC will occur. Normal, normal, then another PVC occur. So it will follow two normal rhythms, and then it goes back to that two normals, and then another PVC occurs. Okay, so what do you think can lead to the premature ventricular contractions? Well, there are so many things that can trigger this to occur. So one of those is the caffeine. Very common. Caffeine or maybe stress, they can develop that as well. All right. Now, your patient with the PVC, they might have the unifocal, which basically means that they have the same kind of PVC. They're quite identical. So just like this one, they have the same kind of form. So this is what we call as unifocal. However, if you're going to see variations of the PVC like this one, it has that upward spike, but this one looks like it has a downward spike. So this is what we call as the multifocal type of PVC. All right, and so when we are going to encounter a multifocal type of PVC, it means that they're arising from two or more ectopic focus, okay, or foci. And they're going to be so different, multiple QRS morphologies as well. Now, what are we going to do here in this patient with a PVC? We are going to treat the cause, because if we are going to let it go, let's say, for example, if we allow it to occur more than 5 or 6 occurrences, then it can lead into ventricular tachycardia. So we want to make sure that we are addressing this. We got to make sure that we're also reviewing the patient's lab studies, maybe potassium, the magnesium. We will review if they're going to have to be replaced, then we're going to have to do that as well. Okay, so treat the cause or review first, review labs. And if there are any imbalances, then we're going to have to replace electrolyte. Replace electrolyte imbalances. All right. Now, again, I've said earlier that if in case the PVCs will be occurring more than 5 to 6, okay, in a minute, you need to notify the medical provider right away, because this is now an ominous sign that your patient probably would go into the ventricular tachycardia. So make sure you're going to notify them and treat the cause. Now we're going to talk this time about the torsades de pointe. And so this is the French term of the twisting of the points. Okay? Again, twisting of the points. The French word of twisting. Torsades de pointe. Twisting of the points. So what you're going to see here is actually a spiraling appearance. There is kind of like twisting appearance of the QRS. So look at that. Here's another one. And here's another one. Twisting of the points. So the QRS has that twisting, spiraling kind of appearance. Now, what do you think can cause the torsades? There's many, okay? One of those could probably be hypokalemia. Causes hypokalemia, low potassium. So usually it will be kind of like low as 2.0 or anything lower than that. Then they're going to develop this one. Now another is hypomagnesemia. Low magnesium level. Hypomagnesemia. Okay. So these are the known electrolyte imbalances that can lead to the torsades de pointe. Now, what would be the manifestations here in your patient? Yeah, it looks busy. The QRS complexes are kind of looking bizarre. Well, the patient here will complain of the same palpitations. Let me erase this. They will complain of the palpitations, signs and symptoms. There will be palpitations. There will be shortness of breath. They probably would feel like they're going to end up falling, syncope, and also chest pain and cardiac arrest. All right. So this is a life-threatening occurrence that needs to be addressed right away. So what are we going to do for this patient? We want to make sure that we are treating, especially if there's electrolyte imbalance, we're going to have to replace the low potassium or low magnesium. We're also going to do cardioversion. So we're going to have to prepare the patient for cardioversion. Okay, let me rewrite those. Treatment would be electrolyte replacement if there is hypokalemia. Or if there's hypomagnesemia, then we're going to have to give the IV magnesium or IV potassium. And we're going to have to prepare for the cardioversion for this patient. Okay. Now, in the long term, this patient will need to have placement of a cardiac defibrillator as well for those high-risk patients. Defibrillator implantation. So that's about the torsades de pointe. Now let's talk about the last one, which is basically the ventricular fibrillation. You don't want to see this, guys. You have to be on your toes when you're going to see this VFib. Okay, so you're seeing here a very rapid, irregular rhythm, and there is no identifiable P waves. None. No QRS complexes, not even T waves. All right, it's just like all over the place. So this is what we call as quivering baseline, or just quivering rhythm. So the ventricles are just quite busy. It's not able to achieve that uniform rhythm. And it's very disorganized within the ventricles. So what do you think can happen into this patient with a VFib? Medical emergency, guys. they're going to be loss of consciousness, there's probably going to be absence of pulse, because the ventricles are no longer able to properly pump, absence of pulse, and there's going to be cessation of breathing. And if you have this patient, okay, so probably you're monitoring this patient, you see that, hey, what's going on? Patient developed this VFib. So you're going to have to intervene right away. When this happens, what you're going to do, make sure that you're going to do the defibrillation right away, okay? So our treatment here is to defibrillate first. Defibrillate. And then you're also going to have to do the CPR, the chest compressions. However, guys, let's say in a scenario wherein you found this patient to be unconscious and it looked in the cardiac monitor that they have the ventricular fibrillation and you don't see the defibrillator nearby, you're going to have to initiate the CPR right away. However, if the defibrillator is already there, make sure that you're going to do this one first, okay? So initiate the defibrillation first thing. So you're going to shock the patient to the heart. Of course, this will restore the normal heart activity. Now, again, once the defibrillation is successful, we are going to treat the patient by identifying what probably could have caused that. Maybe an electrolyte imbalance have caused this problem. Or maybe we're going to have to address the ischemic heart disease that's going on in this patient. All right. So again, our intervention here is to defibrillate, or if the defibrillator is not available, you're going to have to do the CPR. But again, you have a team of nurses in the hospital. You can always call for help, okay? Now, we will be doing the Q&As right now with the first question. It states, a nurse on a cardiac unit is caring for a group of clients. The nurse should recognize which of the following clients as being at risk for the development of dysrhythmia. Select all that apply. A nurse on a cardiac unit is caring for a group of clients. The nurse should recognize which of the following clients as being at risk for the development of dysrhythmia. Select all that apply. Is it a client who has metabolic alkalosis, B, a client who has a blood potassium level of 4.3, or C, a client who has a saturation of 96, D, a client who has COPD, E, a client who underwent stent placement in a coronary artery. What do you think about this test item? I'm seeing ADE by James. Select all that apply. So you are taking care for a group of clients. The nurse should recognize which of the following clients as being high risk for the development of dysrhythmia. ADE, okay, or ABE. I'm seeing AE. Okay. What are the answers for this? The correct answers are letters A and letter D. Just write it down. So we have letter A and we also have letter D, a client who has COPD. Well, if the patient has a metabolic alkalosis, it can lead to the dysrhythmias because of the possible or the electrolyte imbalances that can now impair the cardiac function. Now, if the patient has COPD, what do you remember about the COPD, guys? Remember that there is hypoxia, retention of what? CO2. There is acid-base imbalance. Okay, so we have a question from Rohina. Why not be including? Well, the potassium level is 4.3 milliequivalents per liter. This is within the range of 3.5 to 5 milliequivalents per liter. So we're going to eliminate letter B, okay? Now, if you had answered letter C, a client who has a saturation of 96, that's also normal. No, we're not going to include that in our bucket list. Now, what about letter E? A client who underwent stent placement in a coronary artery. What do you think about that? Well, as we know that the stent placement may increase the cardiovascular risk, but it doesn't correlate with increasing risk of dysrhythmia. It doesn't, okay? So go back into the concept here. We're going to have to identify the factors that will predispose the patient to the dysrhythmias. So for example, if there is a problem with the oxygenation, acid-base disturbance, or let's say chronic conditions, then we're going to associate the dysrhythmias with those, okay? So our focus here is to look for those acid-base or could be electrolyte imbalances. Look for those in these options, okay? COPD or a patient that may have a metabolic alkalosis. All right, let's move on to the next question. The nurse is assigned to a patient who had a defibrillation procedure. Which of the following should be included in the documentation of this procedure? Select all that apply. The nurse is assigned to a patient who had a defibrillation procedure. Which of the following should be included in the documentation of this procedure? Select all that apply. Is it A, follow-up ECG? Let me get rid of that extra A. What are we at? Page 605. 605. All righty. Okay. Again. Okay, the nurse is assigned to a patient who had a defibrillation procedure. Which of the following should be included in the documentation? Is it letter A, follow-up ECG, B, energy settings used, C, IV fluid intake, D, urinary output, or E, skin condition under electrodes? I'm seeing ACD, follow-up ECG, IV fluid intake, and urinary output. ACD. Okay, so the patient had just had a defibrillation procedure. So it's asking this time, what should be included in the nurse's notes? What would be included? So what we're going to have to pick here will be the following. Letters A, also letter B, and letter E. We'll have to check for that. Documenting the client's ECG post-procedure is very crucial, guys, to assess the heart, the effectiveness of the procedure. So we want to make sure that we include this, that there was a follow-up EKG. Also, that there is the documentation on the energy setting that was used during the defibrillation. So this will let the medical team what energy level has been applied for this patient. And we also need to include letter E, the skin condition under the electrodes. We want to make sure that we are assessing that the patient probably that there's no injury, there's no burns or anything like that. Okay, so these are the important elements in our documentation after a defibrillation. Okay, we're talking about the procedure itself, not about the systemic response. Okay, now let's move on to the next question here. A 78-year-old client is admitted to the ED with syncope, shortness of breath, and reported palpitations. The nurse identifies the following rhythm. So take a look into that EKG. The nurse should do which of the following? Select all that apply. Let me reread. A 78-year-old patient is admitted to the emergency department with a syncope, shortness of breath, and reported palpitations. The nurse identifies the following rhythm on the EKG. The nurse should do which of the following? Select all that apply. Are you going to apply oxygen for A? Are you going to prepare to defibrillate the patient? Are you going to monitor the vital signs for C? Are you going to have the patient sign the consent for cardioversion as prescribed? Or is it E, teach the client about the warfarin, Coumadin treatment? Or is it F, draw blood for CBC count and thyroid function study? So we have a patient who has syncope, shortness of breath, palpitation, and look into that rhythm right there. So our patient has a what? What do you think? The patient has the atrial fibrillation in this scenario. So our correct answers here are letters A, C, D. Why? Well, when you are going to have this patient with the atrial fibrillation, with this rapid ventricular response, they're going to end up with low oxygen saturation. There is low tissue perfusion. So we want to make sure that we are administering them oxygen, okay, in order to supplement, in order to prevent hypoxemia in this patient, or to prevent further hypoxemia, I should say. Remember about that AFib that we talked earlier? They're going to end up with shortness of breathing. They're going to be dizzy. They're going to have the syncope. And those are signs that they have low cardiac output. So make sure we're going to give them the oxygen, administer. And then also we're going to have to monitor their vital signs. That's very important to check for their hemodynamic status. Again, looking for a drop in the blood pressure. So what are those signs? Possibly a drop in the blood pressure. Okay. And this will also help us in evaluating the effectiveness of the treatment that we're going to be giving. Now, what's about letter D? Letter D, have the patient sign the consent for the cardioversion as prescribed. Why letter D, guys? Well, the patient, if the patient will have a consistent, or if it doesn't, if it consistently have that AFib, if it remains high, and if the patient becomes symptomatic, we're going to have to prepare the patient for the synchronized cardioversion in order to restart the patient's heart. We want to restore the sinus rhythm. So this will require us to get their consent. Okay, make sure that you have this before that we're going to perform this procedure. Okay, so that is one. Now, why not letter B? Prepare for defibrillation. Is defibrillation intended for AFib? Well, defibrillation is not intended for AFib. Defibrillation is contraindicated. let me just put here CI, contraindicated for atrial fibrillation. This is intended to treat ventricular fibrillation instead. Okay, so for atrial fibrillation, it will require synchronized cardioversion, which is totally different from the defibrillation. Now, if you answered letter E, teach the client about warfarin, Coumadin treatment, and the need for frequent blood testing. I know this is very important for this patient that has a diagnosis of atrial fibrillation, but at this point, when the patient has this acute episode, we want to make sure that we are dealing with this problem right now. The Coumadin will not work instantaneously, okay? So what we're going to select here are those nursing actions that will resolve the patient's decreased cardiac output, okay? So that's oxygenation. I'm going to monitor vital signs to check for low blood pressure, and we're going to have to get the patient ready for the cardioversion, synchronized cardioversion. So letter E is only applicable for a scenario wherein probably the patient is already much more stable, so we can include the teaching. Now, what about letter F? Draw blood for CBC and thyroid function study. Do you think that would help the patient at this instance? No. And of course, the laboratory CBC will not really help out in this scenario, okay? The CBC and the thyroid function is only important to assess or evaluate the probably anemia, could be infection, or it could be any metabolic problems such as thyrotoxicosis, okay? So our goal for this test question is to focus on stabilizing the client's condition. And again, that is the cardiac output. All right. Now we're going to have to talk about the next question, number 4. A client scheduled for electrophysiology studies, or EPS, asks about the procedure. Which statement should the nurse include in a teaching plan for this patient? Is it A, you will continue to take your medications until the morning of the test? B, you might be sedated during the procedure and will not remember what has happened? C, this test is a non-invasive method of determining the effectiveness of your medication regimen. D, during the procedure, the doctor will insert a special wire to increase the heart rate and produce the irregular beats that caused your signs and symptoms. All right, let me reread the question. A client scheduled for electrophysiology studies asked about the procedure. Which statement by the nurse should the nurse include in a teaching plan for this patient? Is it A, you will continue to take your medications until the morning of the test? B, you might be sedated during the procedure and will not remember what has happened? C, this test is a non-invasive method of determining the effectiveness of your medication regimen? Or D, during the procedure, the doctor will insert a special wire to increase the heart rate and produce the irregular beats that caused your signs and symptoms. What would best fit the EPS diagnostic procedure? Well, we have an answer. That is letter D. Whoops. Letter D. Because the procedure itself, right here, it involves inserting a wire into the blood vessel in order to induce the dysrhythmias for diagnostic purposes. If you had answered letter C, this test is non-invasive method of determining, well, it involves insertion of a wire, so it's going to be invasive. So you're going to eliminate that one. Now, if you answered letter A, you will continue taking the medication until the morning of the study or the test. Well, This will require the withholding or maybe adjustment of the medication. So it might require withholding or adjustment. Let me just put here withholding specific medication until the morning of the test. Okay, so you're not supposed to be telling this. You will continue to take your medications until the morning. So possibly they will require withholding those other medications. So eliminate that. What about letter B? You might be sedated during the procedure and will not remember what has happened. Okay, so what makes this item or option wrong? This one right here. Will not remember what has happened. Okay, so the sedation that will be done in the electrophysiologic procedure, it can vary, guys. It doesn't really guarantee a lack of memory of the procedure, so eliminate that one. That's a false info. Now, what about letter C? This test is non-invasive. Yeah, like I said earlier, it is already a non-invasive type of procedure, so you're going to eliminate that one. Let's move forward to the next question, number 5. During physical assessment, the nurse should further assess the client for signs of atrial fibrillation. When palpation of the radial pulse reveals A, 2 regular beats followed by 1 irregular beat, B, an irregular rhythm with a pulse rate greater than 100, or C, a pulse rate below 60 beats per minute, D, a weak, thready pulse. Let me reread. During physical assessment, the nurse should further assess the client for signs of atrial fibrillation when palpation of the radial pulse reveals A, 2 regular beats followed by 1 irregular beat, B, an irregular rhythm with a pulse rate greater than 100, or C, a pulse rate below 60 beats per minute, and D, a weak, thready pulse. We're talking about the radial pulse assessment. What do you think would be the correct answer? So, the correct answer here, guys, is letter B. Very good. An irregular rhythm with a pulse rate greater than 100 beats per minute. Okay, that is our classic assessment finding in our distal pulse check. If you had answered letter A, 2 regular beats followed by 1 irregular beat, what does that mean? Okay, it's not specific to a fibrillation or AFib. Okay, so this is not specific to AFib. So this is something that you can assess in other types of dysrhythmias, so not just isolated in AFib. Now, if you had answered letter C, a pulse rate below 60, so this is what? Bradycardia, right? Not AFib. What about letter D, a weak, thready pulse? What does that mean? It simply means that the patient is not getting good perfusion. Okay, this indicates poor perfusion, but it's not going to be specific to atrial fibrillation. This one right here, weak, thready pulse. So guys, going back into the assessment of a radial pulse in a patient with AFib, that would be letter B, irregular rhythm with a pulse rate greater than 100. Now moving on to the next question, number 6. When teaching a client about complications of atrial fibrillation, the nurse should instruct the client to avoid which of the following? A, stasis of blood in the atria, B, increased cardiac output, C, decreased pulse rate, D, elevated blood pressure. Question. When teaching a client about complications of atrial fibrillation, The nurse should instruct the client to avoid which of the following? A, stasis of blood in the atria. B, increased cardiac output. C, decreased pulse pressure or pulse rate rather. And D, elevated blood pressure. What is the answer? We are seeing letter A. Very good. That's the correct answer. Why letter A? As I have said earlier, when the atria are quivering, it's not effective in pumping the blood from the upper chambers of the heart into the ventricles. It will cause the blood stasis, right? It will lead to the development of the thrombus. Okay? Letter A. Well, AFib doesn't do this. It doesn't increase the cardiac output. No. Decreases CO. Not increase. Decrease pulse rate. Is it true? No. Decreased pulse rate is not typical in a patient with atrial fibrillation. Okay, mostly it is elevated. What about letter D? Elevated blood pressure. Well, this might coexist with the atrial fibrillation, but it's not a direct complication of the atrial fibrillation. Not a direct complication of AFib. We're talking about complications of atrial fibrillation. So you go back into the pathophysiology. What can happen into the chambers of the heart if there is impaired contraction in the atria? Okay. Again, remember the stasis and the risk to developing blood clots. Now let's move forward to number 7. Question states, what should the nurse include in teaching a client about self-care following placement of a new permanent pacemaker to the left upper chest? Select all that apply. Select all that apply. What should the nurse include in teaching a client about self-care following placement of a new permanent pacemaker to the left upper chest? Is it A, take and record daily pulse rate? B, avoid air travel because of the airport security alarms? C, immobilize the affected arm for 4 to 6 weeks? Or D, avoid using a microwave oven? And E, avoid lifting anything heavier than 31 pounds or 1.36 kilos. It's a select all that apply. Correct answers are letter A and letter E. Okay, so what would be the first one? Take and record daily pulse rate. This is very important in the management of their new pacemaker, guys. The patient should be taught how to check their own pulse rate in order to reassess the pacemaker function. This is one, okay? Now, what about letter E? Avoid lifting anything heavier than 3 pounds. That is the correct one because we don't want the patient to have some dislodgement of the pacemaker leads, okay? So we are going to select that. Prevents dislodgement of the pacemaker leads. To make sure that they refrain from doing that for about a good 3-4 weeks. Okay, make sure that you're teaching them about not heavy lifting. Anything heavier than 3 pounds or 1.36 kilograms. None. That's not really heavy, guys, but that's already significant. Now, what about letter B? Pacemakers avoid air travel because of airport security alarms. Do you think that it can, it's significant around this time? Well, the pacemakers will not really trigger airport security alarm, so we're going to have to remove this one. Now, what about letter C? Immobilize the affected arms for 4 to 6 weeks. Immobilize the affected arm for 4 to 6 weeks. That's unnecessary, guys. Immobilization is not required after a pacemaker insertion. Okay, so what we're going to do instead is to encourage early arm movement. Do not immobilize the affected extremity. This is wrong. This is wrong. And what about letter D? Avoid using a microwave oven. Or, yeah. Do you think that's correct? Well, letter D is going to be removed here because microwave ovens do not interfere with pacemaker function. But here's the caveat, guys. In the past, with the older pacemakers, exposing oneself to the microwave oven should be contraindicated. And that is because of the characteristic, the product itself. It will interfere with the function of the pacemaker. But nowadays, with the recent products, then it's no longer applicable. So this is going to be eliminated. All right. So please take note about the technological advances with the new pacemakers. The patient's not supposed to avoid using the microwave nowadays. Okay. All righty. Let's move on to the next question, guys. Number 8. A client in the coronary artery, a client in the coronary care unit has third-degree heart block with a heart rate of 36 beats per minute. The nurse's initial action should be A. Prepare for transcutaneous pacing. Is it B. Prepare to defibrillate the client at 200 joules? C. Administer an IV lidocaine infusion. Or D. Schedule the operating room for insertion of a permanent pacemaker. Let me repeat. A client in the coronary care unit has third-degree heart block with a heart rate of 36 beats per minute. The nurse initial action should be to A. Prepare for transcutaneous pacing. B. Prepare to defibrillate the client at 200 joules. C. Administer an IV lidocaine infusion. And D. Schedule the operating room for insertion of a permanent pacemaker. Your answer? Heart block, third degree. Heart rate of 36. Initial action. So think about a procedure that can be done immediately, okay? That can resolve the patient's third-degree heart block. So look for that answer. You sure? If you had answered letter D, schedule the operating room for insertion of a permanent pacemaker. Guys, the permanent pacemaker will be applicable. It will be appropriate if the patient has hasn't had the third-degree heart block like right now, right? So this is a life-threatening problem. The scheduling will take a while, okay? It will not immediately stabilize the patient, okay? So what we're looking for is the procedure that can immediately stabilize the patient's state, okay? So will not stabilize the patient immediately. So this is wrong. Okay, we're going to eliminate schedule the operating room. What we're going to do instead is letter A, prepare for transcutaneous spacing. As I have said earlier, if the patient becomes symptomatic of the decreased cardiac output, we're going to have to provide temporary support. Okay. Temporary, but immediate treatment. So we need to initiate this one. Okay. Why not letter B? Prepare to defibrillate at 200 joules. Well, the defibrillation is intended to treat life-threatening arrhythmias like VFib or VTAC, but not third-degree heart block. Because if you're going to apply defibrillation into this patient with a heart block, yeah, it will cause more harm. So we're going to eliminate this one. What about letter C? Administer IV lidocaine. What is that lidocaine? This is known to be used for arrhythmias. However, the patient here has what? It would not be effective, guys, in treating the third-degree heart block because it can potentially worsen the heart block here. It can suppress the ventricular activity. Okay, so we are going to eliminate lidocaine because it can suppress ventricular activity. So we are not giving any lidocaine. Nope. Infusion is not appropriate for this patient. IV lidocaine is not appropriate. Now again, going back into the concept about the patient that has a third-degree heart block, think about the cardiac output that is severely compromised. You have to treat this patient's block, possibly with the administration of the atropine sulfate plus the preparation to place the transcutaneous pacer. Okay, and then after that, when the patient's heart block has been addressed, then we're going to have to plan into scheduling the operating room for the insertion of the permanent pacemaker. Okay, so what we're looking for here are those interventions or that intervention that will be needed to prevent life-threatening complication. Now, number 9, a client is scheduled for implantation of an implantable cardioverter defibrillator. The spouse is concerned about what would happen if the device discharges during physical contact. What should the nurse tell the spouse? Again, the question states, a client is scheduled for implantation of an implantable cardioverter defibrillator, or known as the ICD. The spouse is concerned about what would happen if the device discharges during physical contact. What should the nurse tell to the spouse? Is it A, try to avoid physical contact whenever possible? Or B, the spouse will not feel the shock? Or C, the shock would be felt but would not cause harm? Or D, a warning sound precedes the shock, allowing time to move away? So this is a case of a patient that has a scheduled AICD placement. What do you think would be appropriate here? The correct answer here, guys, is letter D. A warning sound precedes the shock, allowing time to move away. So when this happens, guys, the ICD will emit a warning beep, and then it will deliver the shock. And so, again, you're going to have to teach the family member that they should start moving away upon hearing the noise, okay, in order to feel the shock, okay, because this can harm them. If you had answered letter A, let me just mark here as the answer, letter D. If you had answered letter A, try to avoid physical contact whenever possible. Well, that is very impractical, right? Very unnecessary, because physical contact is going to be a normal part of the daily life. And so you want to make sure that they're allowed to do that. Now, letter B, the spouse will not feel the shock. Well, as I have just stated earlier, that it will generate that sound first and will cause that shock into the next person. Okay? Now, letter C, the shock would be felt but would not cause harm. What do you think about that? Yeah, this will partially be correct. Okay, the shock would be felt but would not cause harm. But again, the statement lacks very critical detail, right? It doesn't do that. It will cause harm in some situations. So you got to be careful. Make sure that your teaching is clear to the person, the family member, or whoever is in close contact with a patient. Make sure that they're aware that they should not be getting closer to the patient or touching the patient because this can cause them harm. So this is what's making the statement wrong. Would not cause harm. Okay. Well, let's move on to the next question, guys. Number 10. An older patient or adult is admitted for a permanent pacemaker due to sinus bradycardia. What is a priority goal within the 24 hours post-insertion? Is it A, maintain skin integrity, or B, ensure stable cardiac conduction, or D, or C rather, decrease the cardiac output, and D, increase activity level? Question number 10. An older adult is admitted for a permanent pacemaker due to sinus bradycardia. What is a priority goal within 24 hours post-insertion? Is it A, maintain skin integrity, B, ensure stable cardiac function or cardiac conduction, or C, decrease cardiac output, or D, increase activity level? So what it's asking is the priority goal within 24 hours after the insertion of the pacemaker. What would be that answer? Of course, that would be letter B. Very good. Ensure stable cardiac conduction, because there is already a problem in the transmission of the electrical impulses. This is what we will be checking, okay, to make sure that there is proper conduction of the impulses, okay? We want to make sure that the arrhythmias are going to be prevented. So we want to make sure we are going to check that with continuous cardiac monitoring, okay? So again, that is letter B. If you had answered letter A, maintain skin integrity, well, it is important as well to take a look into the skin, assess the skin, but it's not the immediate priority after the pacemaker insertion. Our focus here is to make sure that the pacemaker is working properly, that it's able to regulate the heart rhythm. So we're moving letter A. What about letter C? Decrease cardiac output. Well, immediately remove that because we're not supposed to decrease. We're supposed to increase CO. Okay? So eliminating letter C as well. Now, what about letter D? Increase activity level. Is that going to be a priority goal after the insertion within 24 hours? No. What we're going to do here is to limit physical activity. Because we want to make sure that the chest leads or the leads in the pacemaker will remain in the correct position inside the heart. Okay? So we want to make sure that the patient is taught, hey, you're not supposed to be doing any more strenuous activity yet. Because we want to check first to make sure that there is no sudden movement. We're not going to cause any complications to the pacemaker placement. Okay, so make sure that they are aware about the physical limitation this time. Now, moving into number 11 here. A client with a new permanent pacemaker is being discharged. What indicates understanding of discharge instructions? Question states, A client with a new permanent pacemaker is being discharged. What indicates understanding of the discharge instructions? Is it A, choose a low cholesterol diet, or B, plans for 1 week of bed rest, or C, verbalize safety precautions for the pacemaker, and D, describes signs of myocardial infarction? The question states, a client with a new permanent pacemaker is being discharged. What indicates understanding of the discharge instructions? Is it going to be choosing a low cholesterol diet, or B, planning for 1 week of bed rest, or C, verbalizing a safety precaution or verbalizes safety precautions for the pacemaker, or D, describes signs of myocardial infarction? Very good, guys. Your answer is correct. Answer is letter C. Verbalize safety precaution for the pacemaker. Like I have said, they need to know that their physical activity will be limited for some time in order to prevent dislodgement of those leads. Remember? If you had answered letter A, choose a low cholesterol diet. Choosing a low cholesterol diet is going to be applicable when the patient have already been taught, or let's say if they have already been able to exercise the precautions, right? So this would not be a high priority for this patient. Diet, low in cholesterol. So this is going to be low priority in this scenario. What about letter B? Plans for 1 week of bed rest. Are they supposed to be on bed rest for a week? I don't think so. The patient will be at risk to developing DVT in this situation. Risk of deep vein thrombosis. So our patient will be allowed certain activity in order to prevent the blood clotting. So not bed rest. That is too much. What about letter D? Describe signs of myocardial infarction. Do you think that's appropriate? Well, it's important for them to really recognize any manifestations of the MI, right? But it's not specifically related to the care of a pacemaker. So there's no relationship with the pacemaker itself and the description of MI manifestations. So we are left with letter C, verbalizes safety precautions for the pacemaker. Now moving on to number 12. A 76-year-old patient presents with a pulse deficit of 48 beats. What intervention may be necessary? A 76-year-old patient presents with a pulse deficit of 48 beats. What intervention may be necessary? Is it A, emergent cardioversion, B, cardiac catheterization, C, hourly blood pressure checks, D, ECG monitoring? Pulse deficit 48. What's your answer here, guys? The correct answer here is what? Letter C. No, letter D. Not letter C, but letter D. Why? Because when we are going to detect a pulse deficit, it's basically detecting the discrepancy between the heartbeats that we are counting and also the pulse that has been felt by maybe another nurse. And so if there is that deficit, this is basically suggesting a dysrhythmia. Okay, so we want to make sure that we are placing the patient on a continuous cardiac monitoring. Pulse deficit signifies cardiac dysrhythmia. All right. So make sure you monitor this patient's cardiac rhythm continuously, not just EKG. All right. Okay, what about letter A? Why not letter A? Emergent cardioversion. Why not A? Well, the emergent cardioversion is only going to be appropriate for much more of a life-threatening dysrhythmia. Not appropriate for a patient with this situation with a 48 beats per minute. It's not a life-threatening condition. Now, what about letter B? Cardiac catheterization. Do you think that this will benefit the patient? Yeah? Well, we know that the cardiac catheterization can give us better information, right? With the structure, the function of the heart, but this is not going to be the first line of checking the pulse deficit. Not first line intervention to check for pulse deficit. Not the first line. So start with the EKG, okay? Now, what about letter C? Hourly blood pressure checks. Do you think that this can help the patient? Yeah, we know that it can help monitor the blood pressure, of course. But again, this is not going to address the pulse deficit. It doesn't. It will only help identify the manifestations, but not prevent. Okay, it will not take care of the pulse deficit. Now, let's move on to the text question here, number 13. A nurse reviews on EKG of a healthy 69-year-old patient during an annual physical. What finding is most concerning? Is it A, right bundle branch block, B, PR interval of 0.21 seconds, C, QRS duration of 0.13 seconds, and D, heart rate of 42 beats per minute? Okay. A nurse reviews an EKG of a healthy 69-year-old patient during an annual physical. What finding is the most concerning? Is it A, right bundle branch block, B, PR interval of 0.21, C, QRS duration of 0.13, and D, heart rate of 42 beats per minute? What is your answer? For this test question number 13, our answer here is letter D. Heart rate of 42. Because in the older adult, especially the 69-year-old adult, it will warrant more investigation because the resting rate here does not usually increase with age, or decrease rather, okay? So we want to investigate further. Needs more assessment, because typically when the person grows older, the heart rate will go up, not go down. So this is something that we need to assess better. Maybe the person now is having degree heart block or bradycardia. Now moving into, what about letter A? What is in letter A? Right bundle branch block. Why is that not the correct answer? Well, when we are talking about the right bundle branch block, it is a conduction abnormality wherein the electrical impulses is not relayed on time, and also it is being blocked by one of the branches in the conduction system. And so this is not going to be applicable into this question. What about letter B? PR interval of 0.21 seconds. PR interval of 0.21 seconds. Okay, so this is basically what? This is within the normal range. Okay, remember about the PR interval? Supposedly it is 0.12 to 0.2 seconds. That is normal. So the patient's value is what? It's actually indicating a first degree heart block greater than 0.21. But which of the following, or which of the two, is going to be much more of a concern? Comparing the two, a heart rate of 42 beats per minute would be much more concerning, as we know that in elderly population, heart rate usually would tend higher, not go lower. With a first degree heart block, we did not have any reports that they are symptomatic, none of that. So it will be a second option instead, not the primary option. Now, what about letter C, QRS duration of 0.13? What does that mean? QRS duration of 0.13. This is prolonged because the normal QRS is what? Up until 0.12 seconds. Okay. And here, this is probably indicating that there is now a bundle branch block or maybe an intraventricular conduction problem. Okay. Now moving on to the next question, number 14. A client is undergoing continuous EKG monitoring while being administered IV medication for the premature ventricular complexus. Based on the rhythm displayed on the EKG monitor, which dysrhythmia does the nurse conclude the client is experiencing? Okay. A client is undergoing continuous EKG monitoring while being administered a medication, intravenous medication for the premature ventricular complexus. Based on the rhythm displayed on the EKG, which dysrhythmia does the nurse conclude the client is experiencing? Is it A, atrial flutter, B, atrial fib, C, ventricular fibrillation, and D, ventricular tachycardia? Carefully select your answer. So take a look into the complexus, guys. Are they uniform? Are they monomorphic or is it polymorphic? Well, giving you the answer right now, this is what we call as what? You sure? Number 14, guys. Take a look into the question. While being administered IV medication for PVCs, based on the rhythm displayed on the EKG monitor, which dysrhythmia does the nurse? Yeah. Ventricular tachycardia, right? We're only going to see the QRS complexus. So that is what is that going to be? Is it D? Right, it is letter D, ventricular tachycardia. Remember about the tachycardia. This is not one of those, yeah, the one that I was talking about, the VFib. That's the one that I don't want to see. So the ventricular tachycardia here, guys, look into the morphology of the QRS complexus. Yeah, it looks very uniform, right? It is very rapid and it originates within the ventricles. It is very rapid. And so what you're going to see is widening of the QRS complexus. Widened QRS complexus. You will see regular, okay? Or I would say not really QRSs, but regular or maybe an irregular rhythm. So as we are seeing the EKG right now. It looks quite regular for me. Yeah, it does. But it's just not the regular sinus rhythm. It's the ventricular tachycardia. So regular or possibly irregular. But as we are seeing right now, this is regular ventricular tachycardia. But again, with this type of arrhythmia, we are going to treat this because we don't want this patient to progress into ventricular fibrillation, which is going to be much more of a life-threatening condition. So our goal here is to treat the patient's ventricular tachycardia. That's what we want. Okay. If you had answered letter A, atrial flutter. Well, atrial flutter is characterized by rapid atrial rhythm. Remember about the sawtooth? We don't have that. Okay, we don't have that scenario, or we don't have that in the EKG. What about atrial fibrillation? If we are picking atrial fibrillation, that's not it as well, because when you are looking into AFib, there is no distinct P waves, and the QRS complexes are narrow. Okay, QRS complexes are narrow. But here, when you are looking into the ventricular tachycardia, the complexes are actually widened. Okay. All right. And there is no P as well. Of course, both of them have no P's, right? The AFib doesn't have P. This one doesn't have as well. We don't see that. Okay. We're only seeing the widening of the QRS complexes. And why not letter C, ventricular fibrillation? Why not that one? Because as with a description of the VFib, this is going to be much more rapid. It's much more chaotic. It also originates in the ventricles, right? But it's just quivering. It is very disorganized. It doesn't have that uniformity in the QRSs. It's not, okay? So looking into the differences between the VFib and the ventricular tachycardia, what you're going to look for is the uniformity of the QRSs, and this is noted as widening. Okay, it could be either with one kind of morphology, maybe just kind of uniform, or maybe a variety. Okay, but here we are seeing a uniform ventricular tachycardia rhythm, not VFib. Let's move on to the next 15. When a client develops a ventricular fibrillation in a coronary care unit, what is the initial responsibility of the first person who reaches the patient? When a client develops ventricular fibrillation in a coronary care unit, what is the initial responsibility of the first person who reaches the client? Is it A, administer oxygen, B, initiate defibrillation, C, start CPR, D, administer IV sodium bicarbonate? What would be that answer? Of course, you're going to have to apply or administer defibrillation right away. And the reason for that is to terminate the ventricular fibrillation. Immediately terminate VFib. First and foremost, do that. We want to restore the normal heart function, because when you have a patient with a ventricular fibrillation, especially with a pulseless VFib, there's no more cardiac output. There's no more blood supply to the brain. The patient will go into a cardiac arrest right away. All right. So we want to make sure that we are treating this with the application or with the initiation of the defibrillation. If you're administering the oxygen first before defibrillating the patient, then you are delaying the intervention. Okay. So should be secondary. This one You can do the CPR if there is absence of the defibrillator, or if the defibrillator is not available yet. Okay, so you will reserve this as a secondary option. Now, letter D, administer bicarbonate. Is that appropriate for this patient? Would you administer the sodium bicarbonate? Well, it can be helpful, guys. It can help in certain situations, especially with metabolic acidosis. But again, this is not going to be our first line of action in the case of ventricular fibrillation. What we need to do is the initiation. We need to normalize the cardiac function. Normalize heart rhythm. That is our ultimate goal here, because if the patient will continue without the pumping, well, what do you think? They're going to go into a cardiac arrest, guys. Okay, so make sure you're going to do the defibrillation right away. Okay, last item. When a client develops, oh, that's pretty much the same. So I guess that's the last item for the day. Well, that's it for this session. I will be seeing you again tomorrow, and we'll be talking about another concept in cardiovascular nursing. We'll be talking about hematological disturbances. And I'll see you tomorrow at 9 p.m. Eastern Time. And I appreciate your time attending this lecture, and I hope that you're learning some things. All right? Thank you, guys. Have a great weekend. Bye-bye.